Okay, so moving on to the next system, respiratory medicine. It's pretty small and convenient. Physiology and basics, control of respiration. Central regulatory centers and central and peripheral chemoreceptors are there. Pulmonary receptors are also there. So, central regulatory centers basically you're talking about brain, middle respiratory center, then apneustic center, and pneumotaxic center. So, apneustic center is located in the lower pons, and pneumotaxic center is in the upper pons. Um, Inspiration is caused by apneustic center, and inhibition, that is excitation and inhibition of the respiratory rate. Pulmonary receptors, stretch receptors are there, and lung distension causes slowing of respiratory rate. So when you deep breath, like when you take deep breaths, you will see respiratory rate goes down. It's called the Hering-Breuer reflex. E10 receptor leading to bronchoconstriction. Juxtacapillary receptors stimulated by stretching of the microvasculature. Okay, central and peripheral receptors. These two basically central are raised hydrogen, that is raised H plus in ECF stimulates respiration. As in, when the pH goes down, the blood is more acidic. It stimulates respiration, acidic blood, to get rid of the acid, to compensate. And peripheral carotid and aortic bodies respond to raised PCO2 and H plus, and lesser extent low PO2. So lung volume and capacity is, you need to know a few terms to understand everything. Lung volume, tidal volume. This volume is the volume inspired or expired with each breath at rest. That is 500 ml in males and 350 in females. Residual volume is the volume of left in the lungs after a maximal expiration. So you take the longest expiration, and then the one that's the air that is left inside the lungs that never comes out is the residual volume, or is the amount of air that is always in the lungs that can never be expired. That is 112.93 liter, not calculated. Increases with age, and FRC minus ERV. We'll come to that later. Is the functional residual capacity minus the expiratory reserve volume. Is the residual volume. Okay, what's the vital capacity? Maximum volume of air that can be expired after a maximum inspiration. So that's like everything. There is almost 5 liter. There's 4.5 liter in males and 3.5 liter in females. It decreases with age. IRV plus TB plus ERV. Alright. Next is inspiratory reserve volume. This one. Okay. The measured IRV equals to VC minus this. So inspiratory reserve volume is the maximum volume of air that can be inspired in addition to the normal. So in addition to the normal tidal volume, the amount you can take in, like the total amount, is inspiratory reserve volume. And expiratory reserve volume is the amount of additional air that can be pushed out after the end of normal expiration. So when you see the chart, it makes more sense. So there is this inspiratory reserve volume and expiratory reserve volume. If you see a spirometry chart, you can understand better. First, functional residual capacity, the amount of air left in the lung after tidal breathe out. The amount of air that stays in the lungs during normal breathing. So after a normal breathe out, the amount that stays is the functional residual capacity. This is the total one. And this includes residual volume as well, and the expiratory reserve volume. So if you see in the graphs, expiratory reserve volume is the amount of air, the additional amount, just not the tidal volume, just the additional amount. And inspiratory reserve volume is also the additional amount after tidal volume that you can breathe in. Both of them are additional amounts. Yeah. So what's next? Okay, next is okay. Note that the functional residual capacity, it cannot be measured by spirometry, but it can be measured with a plethysmograph. Okay, total lung capacity. What do you see in total lung capacity? Total lung capacity is basically the total lung capacity is the volume of air contained in the lung at the end of maximal inspiration. Okay, so total lung capacity is like, is total thing, whole thing. At the end of maximal inspiration, total of volume of lung, the volume of air in the lungs after maximum inspiration, the total amount, as in everything. IRV, ERV, residual volume, tidal volume, all of them together is 6 liter for male, 4.7 liter for females. All together. Okay. Forced vital capacity that is blown up. This is the volume of air that can forcibly be blown out after full inspiration. It's forced vital capacity. And FEV1 is the important thing. So it's forced expiratory volume in 1 second. It's the maximum volume of air that can be forcibly blown out in the first second during the FVC maneuver. Measures in liter. Along with FVC, it's considered one of the primary indicators of lung function. So this is how you decide if it's a obstructive disease or restrictive disease. This is the ratio that you see. So FEV1 by FVC ratio. So this is the ratio of FEV1 to FVC. Now 75 to 80% is normal. Important to stratify COPD. Okay. And some other volumes we'll talk about now. Peaks expiratory flow is the maximal flow or speed achieved during the maximally forced expiration initiated at full expiration measured in liter per second. So this is like not really something to recall all the time. It's like the maximum flow achieved during maximally forced expiration. That is what you need to know. Forced expiratory flow. This is the average flow or speed of air coming out of the lung during the middle portion of the expiration. Okay. Forced expiratory time measures the length of expiration in seconds. And forced inspiratory flow is similar to FEF, except the measurement is taken during the inspiration. Slow vital capacity, maximum flow of volume of air that can be exhaled slowly after slow maximum inhalation. Maximum voluntary ventilation, measure of the maximum amount of air that can be inhaled and exhaled in 1 minute. And forced inspiratory flow, similar to FEF. Slow vital capacity, maximum volume of air that can be exhaled slowly after slow maximum inhalation. All these, you don't really need to know all of these that well. Just read it out and just know for a while. Inspiratory capacity, the maximum volume that can be inspired following a normal expiration. And dead space is the volume of conduction airways of measured with Fowler method. And physiologic dead space, the anatomical dead space plus the alveolar dead space. Okay. Another important parameter is the flow volume loop, which shows the successful FVC maneuver. And positive value represents expiration, that is, this is expiration, and it starts from here. So inspire and expire. So positive value represents expiration, negative value represents inspiration, and the trace moves clockwise for expiration and followed by inspiration. Note that FEV1 and FEV half and FEV3 values are arbitrary in this graph and just shown for illustrative purpose. And for pulmonary function tests can be used to determine whether respiratory disease is obstructive or restrictive, as I've said before. So it's very important. The table below summarizes the main findings and gives some example conditions. Okay, so like obstructive lung disease, FEV1 is significantly low. Like the amount that you can forcefully breathe out in 1 second is significantly low, and FEVC is decreased or normal. Forced vital capacity, is almost low or normal, and FEV1 by FVC is like decreased. So in case you're wondering what's forced vital capacity again, and you can actually wonder because you can keep on forgetting about it. It's the total volume of air that can be forcibly blown out after full inspiration. Okay, so this FEV1 by FVC actually gives you a proportion of the amount of air that is blown out in 1 second. For obstructive lung disease, the examples are very clear: asthma, COPD, bronchiectasis, and bronchiolitis obliterans. And for restrictive lung disease, it's actually, you'll see FEV1 is reduced as well. FVC is significantly reduced, vital capacity is significantly reduced, and the FEV1 by FVC, the ratio is normal or increased because FEV1 is not as down as the FVC. So yeah, you can see this kind of ratio as well. Examples of respiratory lung diseases are pulmonary fibrosis, asbestosis, sarcoidosis, and acute respiratory distress syndrome, and infant respiratory distress syndrome, kyphoscoliosis, neuromuscular disorders. And lung compliance is basically it's defined as change in lung volume per unit in change in air pressure. So the causes of increased compliance can be age or emphysema, and so basically it's the ability to stretch and expand. So it increases with the age and emphysema, decreases with pulmonary edema, pulmonary fibrosis, or pneumonectomy kyphosis. All this can decrease compliance. Now the oxygen saturation curve, which is very important as well, keeps on coming in the exams. And so what happens here is this it describes the relationship between describes a relationship. It describes the relationship between the percentage of saturated hemoglobin and the partial pressure of oxygen in the blood. And it's not affected by hemoglobin concentration but affected by code. So it's not affected by the hemoglobin concentration but affected by its quality. So this is the curve of oxyhemoglobin saturation. It is oxygen bound to hemoglobin and the partial pressure of oxygen. So basics would be here, shifting to the right. For more oxygen, for given oxygen tension, there is decreased saturation of hemoglobin with oxygen. Enhanced oxygen delivery to the tissues. So for the curve shifts to the right, you have to remember that there is more oxygen delivered to the tissues. And shifts to the left, for given oxygen concentration, there is increased saturation of hemoglobin with oxygen, less oxygen delivered to tissues. So it's more likely to go to the cells, hemoglobin, red cells. So shift to right, increase oxygen delivery to the tissues. When does it happen? During acidity or excess carbon dioxide or raised 2-3 dpg, raised temperature. All these things will cause oxygen to go to the tissue. So reduce hemoglobin oxygen affinity in tissues. So hemoglobin oxygen affinity is decreased, so moves to the tissues. And shifts to left, decrease oxygen delivery to the tissues. HBF of these things from low pH, high pH, low hydrogen, that is higher pH, alkali, low PCO2, low 2P3, 2-3 dpg, low temperature. All these things will shift the curve to the left. Higher hemoglobin oxygen affinity in lungs. Okay, and right shift, carbon dioxide diffuses into the red blood cells. Carbon dioxide plus water equals to carbonic anhydrous. Bicarbonate hydrogen. Hydrogen combines with hemoglobin. Bicarbonate diffuses out of the cell. Chloride replaces. Okay, what's the Bohr effect? Increasing acidity of PCA2 means oxygen bind less well to hemoglobin, better tissue oxygenation. So this is what the Bohr effect is. Increasing the acidity of PCO2 means oxygen bind less well to the hemoglobin, so it goes towards the tissue. This is called the Bohr effect. So this shift to right is Bohr effect. And increased oxygen means carbon dioxide binds less well to hemoglobin, better carbon dioxide elimination. Okay. So you have to remember this chart, like which one causes better tissue oxygenation, which one causes better, lung aeration, whatever. Many factors influence the affinity of this binding and alter the shape of the curve. So as I've said, right shift, temperature raised, 2-3 dpg raised, PCO2 raised, PCO low, Bohr effect, raised acidosis, and this is a vice versa. Types of hemoglobin: adult hemoglobin, fetal hemoglobin. For left shift. Left shift of the curve is a sign of hemoglobin's increased affinity for oxygen at the lungs. Similarly, right shift shows decreased affinity, as would appear with an increase in body temperature. Hydrogen ion, 2,3 diphosphoglycerate, also known as diphosphoglycerate, or carbon dioxide concentration, the Bohr effect. Okay, oxygen distribution curve. Shifts right, oxygen delivery is increased, raised acidity. Shifts right, oxygen delivery is increased, raised acidity to temperature 2 dpg in oxygen, increased oxygen in the tissues. and shifts left, it's same thing again. So like, nothing much to talk about here again. Okay. Carbon monoxide has much higher affinity for hemoglobin than oxygen does. In carbon monoxide poisoning, oxygen cannot be transported and released to the body tissues, thus resulting in hypoxia. With fetal hemoglobin, the shift facilitates diffusion of oxygen across the placenta. The oxygen diffusion curve for myoglobin exists for even further to the left. Okay. So these are concepts which have to be really, hard hardwired in the brain. So in case you forget, you have to keep on coming back and understand everything. Transfer factor. It describes the rate at which a gas will diffuse from alveoli into the blood. Carbon monoxide is used to test the rate of diffusion. The results may be given as the total gas transfer (TLCO) or that corrected for lung volume (KCO). So it describes the rate at which the gas will diffuse from one side to the other. So you use carbon monoxide for that, and the thing is called TLCO, total gas transfer. And the causes of TLCO can be asthma and pulmonary hemorrhage, Wegener's granulomatosis, Hood-Baxter syndrome. Anything causing pulmonary hemorrhage will increase TLCO. Then left to right cardiac shunts, polycythemia, hyperkinetic state, gender exercise. Okay. And pulmonary cause of TLC, decreased TLC is pulmonary fibrosis, pneumonia, pulmonary emboli, pulmonary edema, emphysema, anemia, low cardiac output. All these things will decrease TLCO. Transfer factor. So again, we are coming to transfer factor. Anything which causes increased transfer factor is asthma, hemorrhage, left to right shunts, and polycythemia. Low everything else. Okay, where alveolar hemorrhage occurs, TLCO tends to increase due to the okay. This is the reason why we are thinking that why it's increasing. So when hemorrhage occurs, the TLC tends to increase due to the enhanced uptake of carbon monoxide by intraalveolar hemoglobin. Okay, enhanced uptake of carbon monoxide. Alright, so KCO. So KCO also tends to increase with age, and used to diagnose or rule out interstitial lung disease. Some conditions may cause increased KCO with a normal or decreased TLCO, like decreasing the volume, like pneumonectomy or lobectomy. It will cause increased KCO because the lung volume itself is decreased now. And scoliosis, kyphosis, neuromuscular weakness, ankylosis, of course, costovertebral joint, ankylosing spondylitis. Okay, pulmonary arteries vasoconstrict in the presence of hypoxia. A fall in the partial pressure of oxygen in the blood tends to cause vasoconstriction of the pulmonary arteries. This allows blood to be delivered in better areas of the lungs and improve efficiency of gases exchange. Okay, so this was the basics of physiology for respiratory medicine. There are more basic steps which are there. Then we'll go to the disease. Okay, so general respiratory medicine, contraindications for photosynthesis. What are the contraindications? Okay, absolute contraindication, relative contraindication. So absolute contraindication would be uncooperative patient or coagulation disorder that cannot be corrected. Relative contraindication can be site of insertion has known bullous disease, positive end expiratory pressure, PEEP, mechanical ventilation, non-functioning lung. The aspiration should not exceed 1 liter as there is a risk of development of pulmonary edema. Okay, then oxygen therapy. Brace thoracic surgery, 2017 guidelines on oxygen therapy. This opening statement states oxygen is a treatment for hypoxemia, not breathlessness, of course. Oxygen has not been proven to have any consistent effect on the sensation of breathlessness in non-hypoxemic patients. Oxygen saturation targets acutely ill patients 94 to 98, not 100%. So lower supply oxygen to keep saturation within target. However, hyperoxemia has been shown to be beneficial in clinical situations like carbon monoxide and cyanide poisoning toxicity. spontaneous pneumothorax, some post-operative complications, cluster headache, patients at risk of hypercapnia, COPD patients, 88 to 90%. Oxygen should be decreased in stable patients with satisfactory oxygen saturations. Management of COPD patients. Management of COPD patients are prior to the availability of blood gases, use a Venturi mask at 4 liters per minute, aim for saturation 80 to 92. So for COPD, the oxygen aim is lower. And for patients with high risk factors of hypercapnia but no prior history of respiratory acidosis, adjust target range to 94-90 PCO2 is normal. Oxygen therapy should not be used routinely if there is no evidence of hypoxia in myocardial infarction, ACS, stroke, obstructive emergencies, anxiety-related hyperventilation. Okay, respiratory alkalosis acidosis. So acidosis at first we say because this is more common. We see decompensated respiratory conditions like COPD, severe asthma, decompensated heart failure like pulmonary edema. All these things you will see in respiratory acidosis. Respiratory depression, benzodiazepine opiate overdose. Benzodiazepine and opiate overdose can also cause respiratory acidosis. And respiratory alkalosis is basically anxiety leads to that. Hyperventilation, pulmonary embolism can also cause respiratory alkalosis. Cell-accepted poisoning, CNS disorder like stroke, subarachnoid hemorrhage, encephalitis, altitude, pregnancy. All these things can cause respiratory alkalosis. Okay. Salicylate overdose here leads to mixed respiratory alkalosis and metabolic acidosis. So metabolic. Early stimulation of respiratory center leads to respiratory alkalosis, while later the direct effect of salicylate combined with acute failure may lead to an acidosis. So both are there for salicylate poisoning. Okay. NIV. Okay, so non-invasive ventilation. BTS guidelines 2016 on the use of NIV in acute hypercapnic respiratory failure. Some resources would consider CPAP as a form of non-invasive ventilation. However, in clinical practice in the UK, the term NIV is used only to denote BiPAP. Okay, so indications for BiPAP maybe pH less than 7.35, PCO2 more than 6.5, that is 48.75. It's 35 to 45 is normal, so more than 6.5. Respiratory rate 33, and after giving bronchodilators and controlled oxygen. Okay, and then there is neuromuscular disorders. You give if pH is 7.35 less than 3.5, same thing. In the presence of respiratory illness, give NIV if valve capacity is less than 1 liter, if PSO is less than 6.5, and obstructive sleep apnea. Yes, less than 7.35, more than 6.5, same thing. Daytime PCO2 more than 6, somnolent, we have to give BiPAP. Contraindications for BiPAP would be non-invasive ventilation would be severe facial deformity or facial burns or fixed upper airway obstruction, which is there. Relative contraindication if pH is less than 7.15, if pH is less than 7.25 and TCS less than 8, and confusion, agitation, and cognitive impairment. All these things can cause no use of BiPAP as the patient is not really up for it. Okay, NIV monitoring, aim oxygen saturation 88 to 92. If patients requires a high oxygen or rapid desaturation on disconnection, consider mechanical ventilation. Okay, red flags if pH is less than 7.25 on optimal NIV, RR more than 25, new confusion or distress. Actions check synchronization, mask fit exhalation ports. Synchronization, mask fit exhalation port, give chest physio, bronchodilators, consider anxiolytics, consider mechanical ventilation, and NIV settings, full face mask, and then Pressure settings EPAP 3, IPAP 15. Higher in OSAS 20 if pH less than 27.25. So all these are very important. Up titrate IPAP over 32 20 to 30 minutes to achieve slow respiratory rate. IPAP max 30, EPAP max 8. IPAP in neurovascular 10 or 5 above usual. Backup resistance to 20, I ratio COPD 1:2 or 1:3, and OSAS and neuromuscular disorder 1:1. Inspiratory time COPD 0.8 to 1.2 and this 1.2 to 1.5. Use NIV as much time as possible in first 24 hours. Okay. Next topic would be pneumothorax. Okay, next topic is pneumothorax and the British Thoracic Society guideline 2010. Secondary pneumothorax, age more than 50, significant history of smoking, evidence of underlying lung disease on history, examination or chest x-ray. And primary pneumothorax is when it happens maybe due to a trauma or something like that. If size is less than 2 centimeter, if management is here, if size is less than 2 centimeter and the patient is not breathless, discharge should be considered. Review in clinic 2 to 4 weeks. If it's less than 2 centimeter and there's no breathlessness, and aspiration, otherwise aspiration with 16 to 18 gauge cannula. If this fails, then chest drain should be inserted. If it's secondary pneumothorax 1 to 2 centimeter and not breathless, aspiration already done. Otherwise chest drain. Patient cannot travel for 2 weeks and post complete aspiration of the air. Iatrogenic pneumothorax, less likelihood of recurrence than spontaneous pneumothorax. Majority will resolve with observation. If treatment is required, then aspiration should be used. Ventilated patient need chest drain, as may some patient with COPD. So iatrogenic usually resolved by observation. And then if its treatment is required, then aspiration should be done. Okay, rheumatoid and respiratory system. Variety of respiratory problems may be seen in patients with rheumatoid arthritis, like pulmonary fibrosis, pleural effusion, pulmonary nodules, bronchiolitis obliterans, complication of drug therapy like methotrexate, pneumonitis, pleurisy, Kaplan syndrome, massive fibrotic nodules with occupational coal dust exposure, infection, secondary treatment suppression. All this can happen. Chest X-ray cavitation differentials, tuberculosis, lung cancer, abscess with Staph aureus, Klebsiella or Pseudomonas, lung cancer, especially squamous cell carcinoma, weakness granulomatosis, pulmonary embolism, rheumatoid arthritis, aspergillosis, histoplasmosis, coccidiomycosis. All this can happen, can cause cavitation. Okay, so transfusion-related acute lung injury caused by anti-HLA antibodies, human neutrophilic antigen HNA or anti-granulocyte antibody in donor blood. So donor's blood sensitization occurs in multiparous female. Develop these antibodies through exposure to fetal blood. Previous transfusion transplantation patient. When blood is obtained from these donors, it carries high risk for a recipient to develop TRALI. Those who have lung pathology are more susceptible. TRALI symptoms resemble ARDS, and diagnosis confirmed by finding of anti-HLA or anti-neutrophil antibody in donors' recipient blood. Another important topic is ARDS. In ARDS, it's caused by increased permeability of alveolar capillaries, leading to fluid accumulation in alveoli, like non-cardiogenic pulmonary edema. So moving to the next topic of ARDS, very important topic. ARDS is caused by increased permeability of the alveolar capillaries, leading to fluid accumulation and in alveoli. So the capillaries are more permeable, so fluid goes out. And it's also example is non-cardiogenic pulmonary edema. And criteria can be acute onset, bilateral infiltrates on chest X-ray, non-cardiogenic pulmonary artery wedge pressure needed if doubt, and PO2 by FiO2 less than 200. The cause can be sepsis, pneumonia, massive blood transfusion, trauma, smoke inhalation, pancreatitis, cardiopulmonary bypass. All this can be causes of ARDS. Infection is the one which is seen more frequently. Pleural effusion. If it's exudate, it's more than 30 gram per liter protein. Exudate is infection like pneumonia, TB, subphrenic abscess, connective tissue disease like SLE, RA, glucose less than 1.6, LDH more than 700, pH less than 7.2, RF more than 1.3 to increase cholesterol, neoplasia, lung cancer, mesothelioma, metastasis, pancreatitis, pulmonary embolism, Bessel syndrome, yellow nail syndrome, also known as primary lymphedema associated with yellow dystrophic nails, and pleural effusion. Approximately 40% will have bronchiectasis. It's also associated with chronic sinusitis and persistent coughing. It usually affects adults and is very rare. And transudate is less than 30 gram per liter protein. Heart failure, hypoalbuminemia, liver disease, nephrotic syndrome, malabsorption. All these are transudate. Hypothyroidism, Meigs syndrome, triad of ascites, pleural effusion, and benign ovarian tumor. It results after the third section of the tumor. So these are for reasons of transudate. Indications for chest tube insertion in patients with infected pleural effusions are presence of organism on ground stain of the pleural fluid or frankly purulent pleural fluid, pleural pH less than 7.1 in the setting of an infected pleural effusion, loculated pleural effusion, and poor clinical progress despite antibiotic treatment. Bilateral hyaline-lymphadenopathy, bulky mediastinum. The most common cause of BHL are bilateral, if you remember, sarcoidosis and TB, ST. Other causes can also be there like malignancy, lymphoma, pneumoconiosis, borreliosis, fungi, histoplasmosis or coccidiomycosis. All these are there. VHL plus calibration test X-ray. So in sarcoidosis there are 4 stages. Stage 1 is just lymphadenopathy, as you can see here. Stage 2 is lymphadenopathy plus infiltrates. Stage 3 is just infiltrates. And stage 4 is fibrosis overall. So these 4 states you have to remember. LLIIF. Exam. It's very common in the exams. Pulmonary embolism, the important topic. Very commonly seen in the wards. It's PTS published management of PE in outpatients in June 2018, while Mrcp updated its guidelines on investigating and managing PE in 2019. So pulmonary embolism, BT is advised on OP management of PE. Patients with PE should be assessed for suitability for management as outpatients where a robust pathway exists for follow-up. A patient in pulmonary embolism, severity index 75 version, Geneva meeting whatever. Exclusion criteria for OP management include exclusion criteria: hemodynamic instability, more than 110 heart rate, systolic BP less than 100, requirement for thrombolysis or embolectomy, oxygen saturation less than 90, active bleeding or risk of major bleeding, on full dose anticoagulation at the time of PE, severe pain, other medical comorbidities requiring hospital admission, CKD stage 4 or 5, hepatitis thrombocytopenia within the last year. Patients with confirmed PE being treated in the OP setting should be offered either low molecular weight heparin and dabigatran and edoxaban or a single drug regimen, apixaban or rivaroxaban. Patients with suspected PE being treated in the OP setting may be treated with apixaban or rivaroxaban as well, pending diagnosis as an alternative to heparin. Geneva scoring for pulmonary embolism. For risk factor: age more than 65, it's 1, previous DVT 3, surgery fracture of lower limb less than 1 month 2, malignancy 2, and symptoms: unilateral lower limb pain 3, hemoptysis 2, heart rate more than Hottest sign after 94.3, more than 95.5, urinary leg edema or tenderness 4. So less than 3 low, 4 than 10, 4 to 10 intermediate, more than 11 high. So nice recommendation on diagnosis of PE. If a patient presents with signs and symptoms of pulmonary embolism, carry out an assessment of their history, examination, chest X-ray to exclude other causes. If PE is suspected, use the two-level PE well score to estimate the clinical probability of PE. So it's a two-level well score. It's more than 4, it's likely to be PE. Less than 4 is not likely. Clinical signs and symptoms of DVT is 3 marks. Alternate diagnosis is less likely than PE, 3. HR more than 100, 1.5. Immobilization for more than 3 days of surgery in the previous 4 weeks, 1.5. Previous DVT, 1.5. Hemoptysis 1, malignancy 1. So the two-level PE well score, more than 4. So if it's more than 4, offer immediate CTPA, cardiopulmonary angiogram. So if CTPA not available, immediate treatment followed by CTPA when available. So start treatment. And if CTPA is negative, consider a proximal leg vein ultrasound if DVT is suspected. Okay, 2 levels score less than 4. Test D dimer. If D dimer is positive, then do CTPA. If not available, then start treatment followed by CTPA when available. If D dimer is negative, consider other diagnosis. So patients who have an allergy to contrast media or who have CKD, IV, or whose risk from irrigation is high. Assess the suitability of a ventilation perfusion single photon emission CT scan or VQ planar scan. So if someone is having problem with contrast media like allergy or CKD, for CTPA you need the contrast. So if you can't use contrast, then you can go for VQ scan. If offering a VQ or planar scan that will not be available immediately, offer immediate treatment dose. Heparin, start heparin. No molecular with heparin, not heparin if CKD is more than 4. Nice 2090 recommendation on treatment of PE acutely. Offer choice of low molecular weight heparin or fondaparinux to patients with confirmed proximal DVT or PE, considering comorbidities, contraindications, and drug costs with the following exceptions. If EGFR is less than 30, that's when you give unfractionated heparin with dose adjustment based on the APT or low molecular weight with dose adjustment based on anti-10A assay. Or if it has increased risk of bleeding, consider UFH. And PE with hemodynamic instability, consider UFH, and consider thrombolytic therapy. That is unfractionated heparin, by the way, UFH. Maintenance treatment options include oral anticoagulant treatment, warfarin, apixaban, rivaroxaban, or this by an oral, followed by an oral anticoagulant. Offer molecular weight heparin to patients with active cancer for more than 6 months. Offer anticoagulation to patients with confirmed proximal DVT or PE within 24 hours of diagnosis and continue for 3 months. Then reassess the risk and benefits of continuing. Although NICE does not recommend specific assessment tool, dash prediction score for recurrent VTE is commonly used in clinical practice. For people with unprovoked pulmonary embolism, offer anticoagulation beyond 3 months to patients with unprovoked PE. So patients with unprovoked pulmonary embolism, offer anticoagulation beyond 3 months to patients with an unprovoked PE, considering patient's risk of VTE recurrence and whether there are at increased risk of bleeding. Discuss with the patient the benefits and risk of extending their anticoagulation treatment. This is usually at a specialist setting. Offer investigation to assess the possibility of an undiagnosed cancer. Initially undertake a full history and physical examination to look for evidence of malignancy, a chest X-ray, blood test, including full blood count, serum calcium, liver function test, urinalysis, PSA for men. Consider referral for further investigation for cancer with an abdominopelvic CT scan in all people for more than 40 years with first unprovoked PE who do not have cancer features of cancer based on the initial investigations above. Consider antiphospholipid testing before stopping anticoagulants. like anticardiolipin or anti-beta glycoprotein 1 antibodies. Consider arranging hereditary thrombophilia testing and thrombin putting CES testing. If the person has a has a first degree relative who has had a PE or deep vein thrombosis. And then comes dash prediction for recurrent VTE, uh, D dimer, age, sex, and hormone points according to it. Some other points: D dimer sensitivity is 95 to 98%, but poor specificity. VQ SAN is sensitivity 98%, specificity 40%, high negative predictive. CABD gives match defects. Causes of mismatch in VQ scan include all pulmonary embolisms, AV malformation, vasculitis, and previous radiotherapy. Mrcp plus hypertension is thrombolysis. Okay. Occupational and exposure causes of respiratory disease. Occupational and exposure causes of respiratory diseases. COPD causes are smoking, antitrypsin deficiency, cadmium, used in smelting, coal, cotton, cement, and grain. All C's here. And asthma causes are isocyanate, platinum salt, soldering flux resin, glutaraldehyde, flour, epoxy resin, proteolytic enzyme. Diagnosis of occupational asthma: serial measurement of peak expiratory flow are recommended at work and away from work. And asbestos is discussed in the magnetic section. Silicosis is a risk factor for developing TB. Silica is toxic to macrophages. Risk factor for developing TB. Toxic to macrophages, and features can be fibrosing lung disease and eggshell calcification of hilar lymph node. Eggshell calcification of hilar lymph node. Causes of pulmonary eosinophilia: Sharp-Strauss syndrome, eosinophilia, asthma, and hemorrhage. Asthma, eosinophilia, and hemorrhage. Together, Sharp-Strauss syndrome, allergic bronchopulmonary aspergillosis (ABPA), Loeffler syndrome, drugs, nitrofurantoin, sulfonamide, eosinophilic pneumonia, hypereosinophilic syndrome, tropical pulmonary eosinophilia, less common vagus granulomatosis, tropical pulmonary eosinophilia, associated with Bucharia bronchiopathy infection. These are causes of pulmonary eosinophilia. Respiratory infections. Okay. Respiratory infections. First one is community acquired pneumonia, may be caused by Streptococcus pneumonia, 80% of the time. Haemophilus influenza, Staphylococcus aureus, atypical pneumonia like Mycoplasma virus. Streptococcus pneumonia commonly causes deactivation of the herpes simplex virus, resulting in cold sores and associated with foreign travel. And Klebsiella pneumonia, classically in alcoholics. Chest X-ray features may include abscess formation in the middle or upper lobe and emphysema. In alcoholics, Klebsiella, remember that. Mortality 30 to 50%. And Staphylococcus aureus causes pneumonia only after a preceding influenza viral infection, causes multiple abscess in up to 25%. Septicemia develops with metastatic abscess in other organs such as brain and bones. Characteristic features of pneumococcal pneumonia: rapid onset, high fever, periodic chest pain, herpes labialis. Rapid onset, high fever, periodic chest pain, herpes labialis. Pneumonia prognostic factors are SCARB 65, this we all know. Confusion, abbreviated mental test score 8 out of 10. Urea less than more than 7 or more than 42. Respiratory rate 30 per minute. BP systolic less than 90, diastolic less than 60, age more than 65. CARB score 0 to 1 low, 2 moderate, 3 to 5 severe. Okay, other factors associated with the prognosis including persistence of coexistent disease or hypoxemia. Antibiotic choices recommends 5-day course. CARB 0 to 1 amoxicillin. If allergic to penicillin, can give or to some give doxycycline or macrolide. erythromycin. Oral amoxicillin if start source 2. If atypical start suspected, add macrolide like erythromycin or erythromycin. And if penicillin allergic, doxycycline. Carb 65 more than 3, coamoxiclav plus erythromycin or erythromycin. If penicillin allergic, levofloxacin. So fluoroquinolones may cause disabling and potentially long-lasting or irreversible side effects affecting musculoskeletal nervous system. Stop treatment at first signs of adverse effect. This is tendonitis. Important. Tendonitis and fluoroquinolones. Presence prescribed with special caution in more than 60-year-old and avoid co-administration with corticosteroid. Mycoplasma pneumonia is a cause of atypical pneumonia which affects children and young adults. Frequently amongst those living in boarding house, housing and hostel. It's associated with a few complications such as erythema multiforme, target lesion and cold autoimmune hemolytic anemia. Pneumococcus may also cause erythema multiforme. Epidemics of mycoplasma pneumonia classically occurs every 4 years. It's important to recognize atypical pneumonia as they may not respond to penicillin or cephalosporin. So this is something you have to look up for erythema multiforme, target lesion in mycoplasma pneumonia. So features can be flu-like syndrome, classically preceded dry cough, bilateral consolidation on chest X-ray. So there's a hint: young patient with chest infection and hematuria, mycoplasma pneumonia. Chest infection and hematuria. Young patient, chest infection and mycoplasma pneumonia. So complications can be cold agglutinin IgM may cause hemolytic anemia. So that's why the hematuria is coming up. Thrombocytopenia as well. Erythema multiforme, meningoencephalitis, GBS, septic meningitis, bullous meningitis, painful vesicles on the tympanic membrane, pericarditis, myocarditis, gastrointestinal, hepatitis, pancreatitis, renal, acute GN, polyarthritis. Diagnosis can be done with mycoplasma serology. White cell count is usually normal, but ESR and CRP is increased. Coombs test can be done. Positive in 50 to 70% may produce false positive in measles, infectious mononucleosis, adenovirus, and others. So Coombs test can be positive for this. Mycoplasma serology and Coombs test can be differentiated from other type of pneumonia by the relatively slow progression of symptom, lack of bacteria in a gram-stained sputum, and a lack of growth on blood agar. So management duration of treatment is 24 days. Start macrolide like erythromycin, clarithromycin, or azithromycin. Tetracycline is an alternative. Okay, PCP.